Right. So thank you for joining. This is our seminar series, our research roundtable that we host quarterly through the Group Wellness Visits for Babies and Family Research Network. We're so glad you're here. We hope that we can share a dialogue and we'll have time for questions and conversation at the end of the presentation. We have Astrid Van Dam here, and we're so thrilled to learn more about the Group Care 1000 project, the 7-country study of group care implementation. So much to learn about different health systems and different structures and implementation. Our network has kind of 2 membership levels. We would love for you all to join if you are not a current member. We'll go ahead and drop the link into the chat for membership registration. We have a higher tier, sort of investigator or steering committee level membership, where you're sort of contributing and guiding to research direction and strategic planning for the network. And we have a general network membership level where you enjoy the resources and offerings throughout the year, as well as receive newsletter updates and our seminar series and other sorts of events like our open house. And then our regular meeting updates where we talk about projects. So you're invited to attend several meetings throughout the year with us, as well as we have had our 2nd annual group care kind of leadership meeting in Boston with a relational health track. And we anticipate next October, also hosting that event in Boston for you all to meet and gather in person. So we will share dates as soon as we have those for the following fall. Here is the QR code directly to the membership registration form. If you have access to a smartphone and would like to take a picture, you're welcome to access the registration form there. Again, you're directly added to our listserv and you will receive updates about our upcoming events. Just looking forward for the next few months, we have a steering committee meeting in December 18th. In January, we have a group care leadership workshop, continuation and discussion. In February, this is an open meeting for anyone in the network to attend. This is where we talk about our different projects in different areas, research projects around centering parenting, of course, as well as diverse projects looking at implementation. We have another project we're excited to talk about that's Massachusetts focused around implementation of dyad group care models, not specific necessarily to centering. And then later in February, we have our annual open house. And then coming in March, very excited for this upcoming seminar. Please mark your calendars. Dr. Cynthia Osborne from Prenatal to 3 Policy Center will be talking about the research they do to advocate for important policy change at the national level here in the US. And that's the Research Roundtable Seminar, March 17th. And again, if you're on our listserv, you'll receive updates and announcements for all of these events.
How are you?
I'm okay.
Without further ado, it looks like someone might be off mute. Here we go. Thank you for your patience. Okay. Without further ado, I'm so pleased to introduce Astrid Van Dam, who's really leading the effort in terms of international group care research. She is a trained midwife with several years of experience in postnatal care, a researcher within the Nursing and Midwifery Research Group at the University in Brussels, and co-founder of Group Care Belgium, a nonprofit organization serving as a national knowledge hub for all aspects of group care, training, technical assistance, coaching of healthcare settings, and the development of support materials for implementation. She has been conducting research on group care for the past 5 years and is passionate about the group care model, as we all are, empowering families and healthcare providers and fostering international collaboration with researchers worldwide. Astrid, thank you so much for being here today, even a very far away and in your evening hour. Thank you. And I'll pass the screen share over to you now. And then we can spotlight you.
Okay, thank you. Thank you for the introduction and thank you for having me. Really glad to be here. So Yeah, so I'm going to talk about the implementation of group care in 7 countries, so within the Group Care 1000 research project this evening. Claire, you already introduced me, so thank you for that. So I'm going to skip the first part. I just wanted to add, so I'm talking here this evening or morning or afternoon, wherever you are in the world. But this is actually really work of a big group, the Group Care 1000 Consortium. So here you can see a group picture. So I'm just one of them, and we really made this work together. So I'm presenting in name of the whole group, I would say. Yes. So we started the Group Care 1000 research in 2020, really with the aim to develop like systematic and in-depth understanding of feasible and sustainable ways to really integrate group care into the health systems for antenatal and postnatal care. So it's not focused only on postnatal or only on antenatal, it's really a combination, and depending on the country, they decided to implement antenatal or postnatal care. So these are the participating countries. So within Europe, we have Belgium, the Netherlands, UK, Kosovo, and then we have Ghana and South Africa and Suriname. So it's really diverse mix of countries, which makes it really interesting to work together to implement group care. So this was like the overall GC 1000 plan, but today I'm only focusing on the first two parts, which are part of my PhD research. So really the pre-implementation part, the context analysis, etc. And then after that, the actual implementation started, evaluation and dissemination. But for today, I will focus on the first two parts. I know almost everyone knows about group care and the details, but very short, just to make sure we understand each other. We have the same understanding of group care, centering-based group care, so based on centering pregnancy, centering parenting model. So 8 to 12 pregnant women of the same gestational age come together for 10 times, 9 times during pregnancy, once postnatal if it's antenatal care, for 2-hour sessions. The healthcare is included. It's facilitated by medical healthcare providers, and there is a lot of time to discuss all kinds of interesting topics. So we really focused on including all of the 3 core components for all the sites that participated. So the health assessment had to be included. So it's not just a talk, but it's really the health assessment included, interactive learning and the community building. So they were all included in all the implementation sites within the Group Care 1000 research. Yeah, as we know, the model itself, it has shown really great outcomes already. So it's, at least an equivalent alternative, but of course we are all very passionate about it, and we can see really much the advantages of the model, like higher attendance rate, but also the impact on vaccinations, etc. And the satisfaction with care, of course, as well. So that was the start. So really deciding what do we understand with group care, make sure all the countries and the sites were on the same line. And then we performed a context analysis, and we used the rapid qualitative inquiry methodology to do so. It's a methodology really specific for context analysis in complex situations, because we wanted to get understanding on how to integrate group care, but we wanted to see if we could see like similarities between all those diverse countries and sites, to have like recommendations that could apply more globally or universally, and not very specific to one site, which is quite often the case in research, that it's really focused on one site. So therefore we use the rapid qualitative inquiry also because it's more time and cost effective. It's actually like in 1 week per site, and that we conducted interviews, focus group discussions, site visits, etc., with a research team. So it's very intense, but on a short time, really concise. And we wanted to develop like a supporting framework to map the anticipated challenges. So it was pre-implementation, as I said, to the implementation of group care. This was my part of the aim. Of course, there were colleagues also focusing on the needs of the women and other parts of the context analysis, but my focus was on specifically on these anticipated challenges and the need for adaptations prior to implementation. So as I said, the countries were really diverse. So we had low middle income countries, high income countries. We had countries implementing antenatal group care, other postnatal group care, other countries implemented both. We had very different healthcare systems to implement group care. So we had midwifery-led care systems and obstetrician-led care systems. We had countries that did have experience with group care and others didn't have any experience at all. And then we had countries focusing on a specific target population and others who wanted to implement it within their site for the general population. So all the pregnant women or all the babies that are attending there. So this diversity was really interesting, as I said before, but it also made it quite complex. So to conduct a context analysis, we really worked together. So me and my colleague Nela Martens from the Netherlands, guided by our supervisors, of course, were the project researchers. So we were involved in every context analysis in all those 7 countries and all the participating sites. And then within each country, we worked together with country researchers. So they were, of course, more familiar with the country-specific parts. And then we also tried to work together with a community researcher, which was site-specific and which was actually not a real researcher. So that could be a midwife at the site, a coordinator at the site, someone involved in implementation who could provide more context-specific information, more specifically during the debriefing. So after every day in the field, we had a debriefing to discuss the interviews, and there the community researcher could provide more context. On the one hand, this was very positive because you have that context-specific information. It's really nice to get the site more involved. You can feel there is more buy-in for the research part, but also for the implementation of group care. So it's really strong, I think, to connect with the sites and to involve them, especially because it was, for example, also to co-facilitate focus group discussions. But for the daily debriefing, it was not, it was like sometimes a thin line between what can we say or not, because some issues might be sensitive. So it was, for example, we had a midwife in the practice and we interviewed her colleague. So then it's, of course, very sensitive to discuss what her colleague may have told about the working atmosphere at the site, for example. So we didn't manage to have a community researcher in each country. I think we learned a lot, and I think you really have to think it through how you will work together as a team and make this community researcher a real team member without compromising the protection of your interviewees. So I think that's really a lesson learned, and I think we learned a lot. I would do it again, but maybe in another way and maybe a bit more planning in advance on how to have this community researcher more involved. So we did train, my colleague Nele and I, we trained the local researchers and the community researcher in this methodology of the rapid qualitative inquiry and interview. So it was also very interesting that we had different backgrounds. So in our research team, so we had backgrounds of midwifery, psychology, sociology, anthropology. So it was really nice to have all those perspectives as well for this work. And then, so we interviewed in each site. We said we at least wanted to interview the future facilitators, so those who were assigned to be the facilitators once the group care sessions would start. pregnant women or parents, depending on anti or postnatal care implementation, and other key stakeholders. But we really asked the sites, the coordinator at the site, who would be important to interview. We did not decide for them. So, for example, like in Suriname, there was a really interesting interview with the church leader. But also we interviewed local charity organizations, hospital managers, really depending on who may have influence on the implementation of group care here in your sites. So that was quite interesting. We also designed a vignette, so a video with like a short story, just very describing how a group care session looked like from this perspective from one woman. And we adapted it in the local language. We added local pictures, changed the names to make it fit in every country. We did this together with the local researchers and checked with the community researchers if this would fit for the interviewees at their site. And we also really thought this through to give like sufficient information to get the concept of group care, but not going too much into detail. And we didn't speak, for example, about known results or something of group care or outcomes or something. It was very neutral. So we did not say the positive things. We just described it to have a neutral start. And it was the same for every interviewee in every country. So that was really nice from the research perspective to have the same line in every country, in every site about the information they got in advance. And this was the framework we used, so the consolidated framework for implementation research. This guided our topic guides and also the debriefings. As I said, after every day in the field, we came together and discussed everything, all the interviews, and we did this based on the consolidated framework. So we checked if we covered every aspect of the framework that could influence the implementation of group care. So you have the intervention itself, the inner setting, so the organization in which it's implemented, the outer setting, so the broader context in which it's implemented, the individuals involved, both the healthcare providers and the target population, and then the process, planning, etc. So we checked in every country, in every site, if we got every piece of the puzzle and be able to get an analysis on the anticipated challenges. So, and based on all that information, so we had the interviews, focus group discussions, site visits. We did a document analysis, so the antenatal postnatal care guidelines from the country, from the site, so local or federal. And then we had the debriefings, and we combined all that information to develop the anticipated challenges framework. We tried to include only anticipated challenges that occurred in every site, in every country. So we adapted the framework iteratively, continuously. After every rapid qualitative inquiry, it was adapted to end with a framework that was applicable in every site. So in total, we conducted 330 interviews. We did 10 focus group discussions. Unfortunately, it was during COVID time. As I said, we started in 2020. So these rapid qualitative inquiries started about November 2020. But even then, we had a lot of COVID fluctuations. So unfortunately, we were not able to conduct as many focus group discussions as we had planned or as we wanted. And then these are also the debriefings we included, as this also gave us a lot of information and was really included as data. It was really a data source. So this was then all those interviews and data collection was then the base for the framework. So here you can see all the anticipated challenges that occurred in every site, in every country. And we divided it into surface structure anticipated challenges and deep structure anticipated challenges. And the first group, it's often able to just tackle them within the organization that is implementing group care. And then you have the deep structure anticipated challenges, which are more often really rooted into the healthcare system, into the culture, and are much more difficult to tackle. So yeah, some are quite obvious, like the content and materials that should be adapted. For example, like in South Africa, HIV was quite a big issue that should get a more central place as a content, as a discussion topic. Also the materials, for example, like in Suriname, they said like, it doesn't make any sense to show us pictures of healthy food. We don't have that food here. It's pictures from outside of Suriname. We don't have it, so it doesn't make any sense. So quite obvious things, but still important to think about it. Also about the facilitators, the selection of the facilitators. In some sites, for example, they only had one midwife. So then, of course, you cannot have two midwives for one session. So you have to really think about the co-facilitator. But also, like, for example, in Belgium, they decided to focus on the families living in vulnerable situations. So they had a midwife together with a social worker to get the social care immediately involved. It could be a combination of a midwife with a psychologist, for example, or a health visitor with a midwife. So the anti and postnatal care already together as facilitators. And they all stated that they wanted the group care training because it's not covered in regular education, midwifery education. Yes, and then timing and location, really depending on the availability of location. Also, the timing often depended, like is the waiting room available empty at the time? Or for example, in Ghana, it was more like when it's not too hot to have a tree that can provide some shadow. So that was really interesting how the same issues occurred in every country and all in very different types. So that was interesting to see. And also the group composition, as I said, some decided to focus on a specific target group, and others really wanted to implement it for everyone. And then we have the deep structure anticipated challenges, which are more the health assessment. So it was both but it was quite obvious that people wanted group care and the information and interaction and community building. They're all very supportive, but integrating this health assessment is quite challenging. And that was like the most challenging aspect. Both integrating the self-assessment, where we could see that it were more the healthcare providers themselves who were more reluctant and maybe doubted the capabilities of the women to, for example, measure their blood pressure. But actually, during the interviews with the women themselves, there was actually only one woman who stated, like, I don't want to do this. I prefer the midwife to do this. She's trained for it. But all the other women just say that, I can do it. I want to do it. Just teach me and I will do it. So that was quite interesting in having all these interviews to really keep in mind the perspective of who is saying that, because most of the women really were very open to it and supportive for the self-assessment. And then the other one, so the scheduling it into the regular care also has a link with the health assessment. So it was sometimes tricky to have this care as additional care. So they would still go for their regular care, medical care, to the regular care that was provided, and then go to group care as additional care. So that was quite difficult to really integrate it and see it as a standalone care. And also, there are a lot of things that you have to keep in mind if you schedule it, and it's very different in every country. For example, postnatal care, the vaccination dates are very different. Developmental screenings are very different on what time. So it's needed to adapt it and to really make it fit. If you want to have a sustainable implementation of group care, you really have to make sure that you have a good information and good insights in the regulations in that site and in that country before you start implementation. And then enrollment also very difficult in every country. Expected to be difficult to motivate women because it's something new often because it's pre-implementation. The sites didn't offer it yet, so that was also very important to take into account and to really have an action plan, like what will we do, how will we do it, who will be involved. For example, quite some facilitators were like really motivated to organize group care, but they didn't really think like, how will the women reach me? And it's very important to know and to think about it in advance. We also saw that within this project, they all work together with partner organizations, possible partner organizations. It's really difficult to just start this on your own without any help. For example, for enrollment, but sometimes also for the venue, for location, for multiple aspects, and of course the financial aspect. Very different in every country, but it's important to get insights in how antenatal care or postnatal care is financed before you can make recommendations on how to reach a sustainable implementation of group care. So these were the results of the 7 countries, really short. And then now I will just focus a little bit more in depth on the results that we found in Belgium. In Belgium, for this project, there were 3 sites, but all antenatal care. So there was no postnatal care sites involved. Yeah. So as any other country, we have our own characteristics. So we really wanted this in-depth context analysis. And we had 2 primary care sites, which was actually collaboration of different sites, community healthcare center, organizations against poverty, midwives. And then we had 1 collaboration of hospital with the primary care midwives. And we wanted to get insights in these anticipated challenges for group care implementation in Belgium. So just to give some information on current routine antenatal care in Belgium. So actually the women, if they're pregnant, they can choose for who to go to for their pregnancy follow-up. They can choose between a GP, a midwife, or an obstetrician. But in practice, we see the majority of the women they choose for obstetrician-led care. So it's really dominantly obstetrician-led. If it's a first pregnancy, they will schedule 10 visits. If it's multi-gravida, it will be 7 visits during pregnancy. In the official guidelines, 3 ultrasounds are recommended, but in practice, much more ultrasound examinations take place. So it's very medicalized antenatal care in Belgium. So I think that's important to know before we start here. So in Belgium, we conducted 48 semi-structured interviews, so with facilitators, service users, so the pregnant women living in vulnerable situations, because that was the target population in those sites, and other stakeholders, policymakers, healthcare managers, etc. And we identified like 3 overarching themes that influenced the whole implementation of group care in those sites. So the first one was the fact that they focused on vulnerable pregnant individuals as a target group. And that had multiple implications. And it was really because of, well, they sound quite obvious, but it was you could see that the sites only really thought this through after this context analysis and really showing this. For example, to form your groups to get 8 to 12 women together, you have a really small eligible pool of pregnant individuals if you select only a small part of it. And they're very dependent on others. So you could see that they already collaborated between multiple sites, but even then it would still be difficult to form groups that are big enough. And as an extra difficulty, there was at that time no universal screening tool or about the inclusion criteria. So it's very difficult if you need, as a midwife, if you need the GPs or the obstetricians to refer the women to you when they're pregnant, and you just say, we focus on families living in vulnerable situations, but you don't have inclusion criteria. It's very difficult for them to refer to the groups. At this time, we do have a screening tool, so the Born in Belgium screening tool, which is specifically developed to screen vulnerability during pregnancy, and it's available for free for the organizations, healthcare providers. So now the tool exists, but at that time it did not. And that was a major issue. Also the stigma, so the fact that they only invited those families. The healthcare providers didn't feel really safe to invite them. You can see here a quote of a community healthcare center coordinator. She stated it's like difficult for her to tell the mothers that it's specifically for them. So why do I invite them to the group and not another mother? So that's, yeah, quite important. But it was also remarkable that only few healthcare providers or interviewees really thought about the stigmatizing effect that it could have to only select those women from your site. And then, of course, language also, yeah, of course, has a lot of influence, especially in a model group care, which is really based on communication, interaction, learning from each other if you speak other languages. And then the accessibility, because they often depend on public transportation and tend to have less childcare. So if there are other children, it's also more difficult to attend groups. And then the second theme was a need for, well, actually for two mindset shifts. So the first one from individual care to group care, which is the same in every country, of course, both for providers and participants. But specifically here in Belgium, the issue was more the shift from obstetrician-led to midwifery-led, because the group care sessions are led by midwives. And as I said before, women are really used to have obstetrician-led care here. So that is a major challenge in Belgium for group care, to convince the women to they're not just choosing for care in group, but they also choosing for care by a midwife instead of an obstetrician. And our interviews, well, they show that on the one hand the women are open to have their care in group by a midwife, but on the other hand they also confirm that they really trust an obstetrician. They like their ultrasounds every time they have their antenatal care visits. So it's a really difficult one. And then the third one was that we really saw that to make group care possible in Belgium, they really relied on stakeholder buy-in within the organization. So they appointed a coordinator in every site to be the central contact point for all those collaborating organizations. They needed each other for enrollment, for the venue, to make this possible. And then also with partner organizations, also for example, enrollment. And it was really interesting here that we could see the different point of views as an incentive to support the group care implementations. And I think I would really recommend to talk to a lot of people if you want to implement group care on what would convince them to refer women to group care. Because, for example, the gynecologist, she really stated very clearly that it's just about outcome, medical outcome. That's the most important thing, not for the pleasant social atmosphere, the coffee. It's really just because it has been proven to simply have a better outcome. So then you will not convince her just by stating that the provider satisfaction is better with group care. But then, for example, the social worker, she really thought about the social support, and that would be her reason to refer women to group care. So this, including these different point of views, appear to be very important here. And then we have the overarching political situation. Of course, the health insurance system that is paying for this medicalized care. It is also possible in Belgium actually to have like both group care and obstetrician-led care. It's paid by the health insurance, but of course that's not what we want. It's just very expensive antenatal care then if you have both. It's really, yeah. So some points of reflection in the end. So we really saw that these challenges quite some are related to group care, but quite a lot are also related just to implementation in general. If you implement a new model of care, some challenges are the same, but here specifically, we could see that like working with these families in vulnerable situations, the language barriers, the access barriers, they also exist without group care, but we see that the group-based and collaborative nature of group care can really amplify how these challenges manifest. So that's really important to take into account. So like this multiple complexities really intersect with each other, like the stigma risk, the smaller eligible population, and then the language, as I said, because the model is really dependent on the communication and the group dynamics. So that's an important one. Another important one was that so they decided to focus on these families in vulnerable situation. Quite some research has shown very positive outcomes, specifically for this group, but that research did not select the women based on their vulnerability. So that was really important. That was not taken into account when it was decided to focus on these vulnerable groups. So we saw actually that only focusing on selecting them, having the vulnerability as an inclusion criteria was not the way to go because of the stigmatizing, because of the small pool, etc. So it also has changed. So we decided to really more have an open view, and it's like finding a way to be able to reach the families in vulnerable situation, but not include them because of that. Yeah. And then we also saw that most of the challenges actually originate in the outer context, so in the broader healthcare system culture, and then this way spread across the other domains of the consolidated framework, so the inner setting, etc. And of course, here the most prominent was the medicalized obstetrician-led pregnancy care, which is a really dominant culture here, and it's contrasts so strongly with group care's philosophy of normalization, empowerment, peer support. So that has a major influence. And made it more difficult to have this antenatal care, to find a place for group care in this antenatal care trajectory. But in that sense, it's like a major difference compared with postnatal well-baby care in Belgium. As I said, this was not included in this research, but I did work in antenatal and postnatal care in the well-baby care in Belgium, and it's really well organized here in Belgium, so it is offered by the government. It includes vaccinations, home visits, developmental screening, etc. It's for free for the patients. It's no matter if you have insurance or if you're illegal, everyone is welcome. Every baby is welcome, and parents don't have to pay for it. It's very structured. So in that sense, group care would fit much more easily in this postnatal care system in Belgium compared to the antenatal care system. So of course, we hope that women in Belgium would get a chance to go for parenting care, for postnatal care, that group care would be an option as well for them. Because a lot of challenges that we identified, such as enrollment, the venue, the role clarity, would all be less of an issue in postnatal care in Belgium compared to the antenatal care. Also, the social care is already taken care of within this organization, so that's also less of an issue here. So that's what we hope for. And another reflection is that this integrating care for mother and baby is also very interesting perspective. Not specifically for Belgium, but worldwide, we could see that it's really fragmented, the care for the mother and the care for the baby, and group care could as well there be a really nice opportunity for that. And we also wrote a paper on that. I added the title there. Another reflection, which I'm really a strong fan of, is including the mental health care, more specifically, both in antenatal and postnatal care. We do have a case example in Brussels, in the hospital where we work. The group care sessions are provided by a midwife and a psychologist. So both in antenatal and postnatal care, you have a midwife and a psychologist, which is really nice. And we interviewed women, not for this Group Care 1000 project, but for another of my colleague, Florence Stalrich, her project. And the women are really enthusiastic, really stating that they did go and seek for mental health care, individual care, because of the fact that they knew the psychologist and the threshold was so much lower because they knew what it was. Yeah. And then, of course, we also have the other domains that group care could be applicable. We also have the example in our hospital where group care is offered to cardio-oncology patients, so women that ended their breast cancer treatment and they still need medical checkups, etc. But they also start working and going back to real life after cancer treatment. And I think it's about the fourth session that the fourth group that started now, and they are also very enthusiastic about it. So it's also really nice to see how the model of group care is also applicable in a lot of other domains. So, and here are some pictures of a group care session in Brussels, guided by a psychologist and a midwife. So that was it from my side for today. Thank you for listening, and I'm happy to answer some questions if there are. Thank you.